have all my records already.
Oh, yeah.
Good,
Yeah, you did a real nice job summarizing all that.
good,
Usually I did it, but you got on a roll, so I let you do it.
good.
You know, when we look at the bladder cancers, you know, a lot of it we'll look at the extent of the tumor or the T stage. You know, there's no evidence that there's any lymph nodes. There's no evidence it's spread anyplace else. And, you know, part of that T stage is the depth of invasion into the wall. And, you know, sometimes that gets tricky because, you know, we're looking for how far into the muscle. And, you know, they go in there and they scrape it. And, you know, if you think about it, you're kind of shelling it out from the inside. And so you want to be aggressive, but you don't want to put a hole in it. So, you know, they called it T1, but certainly by the looks of it, that seems to probably underestimate it. When he did the exam and felt around, you know, when you're out for the cystoscopy, you do the rectal exam, and I think in his notes he was suspicious that it's, you know, it's a little more extensive and
onto the ureter tube.
I'm not sure if he said that. Based on the scans, yeah, and the fact that it is, you know, the way it is causing the hydronephrosis.
Which is the keeping of the urine in your
Yeah. Where's the...
I didn't understand why they didn't take any negative tissue.
I'm not sure what you mean.
On the, you know, on the area around the growth that's...
You mean like a margin?
Yes.
That's something that with a bladder tumor...
It's too hard to do?
Yeah, it's a little... that's different here.
Okay.
We can talk about that. Yeah, so actually it's more the hydronephrosis. But, you know, probably T2, maybe even T3. You know, so it's something like, you know, breast cancer, you got the lump, you got, you know, you take out the tissue around it, you check those margins. So
right.
You know, it's easy to take a big chunk around it. You know, with the bladder, you got the tumor kind of here, and, you know, something like that. Basically, you're trying to debulk it, get a diagnosis. That's, you know, when they do that, that's not an operation for a cure. You know, the curative operation would be to go take the whole bladder out and then look at those margins.
Okay.
So this is, you know, when you have breast cancer, it's almost kind of the equivalent of when they do a core biopsy.
Right.
It's a little more than that, but it's more like that. Get a diagnosis, get that tissue out and debulk it.
Now, he said that he felt like he got it all.
They take out everything they could see, but yeah.
On the inside.
Yeah.
I'm talking about on the inside.
Exam. Yeah. So, you know, the options, when you look at the guidelines, really, you know, number one is doing the chemo and then the surgery.
Chemo first?
Yeah. And then surgery, and that's taking out the bladder. And, you know, in terms of chances of being cured, getting rid of the cancer, that's number one. You know, when we have the guidelines, they'll like list categories sometimes. You know, most of them are 2A is, you know, but when there's, you know, really good evidence, you know, high quality evidence, those would be category 1. And that's a category 1 type of thing. You know, well tested, that's the best way to get rid of this, you know, completely eradicate it and being cured.
But it could come back.
It could come back, but it might
But
not.
at 82, you know what I'm saying, Doctor?
Yeah, and we'll come back to that.
Yeah, let him finish his options for
Okay.
you.
Well, I don't like that option.
Okay, but even if the chemo, look at how well I responded.
All right, I'll listen.
Number 2 would be chemo and radiation. And that certainly has a chance of getting rid of the cancer as well, you know, curing people. When you look at the numbers, with the surgery versus the chemo and the radiation, there's kind of an overlap, but, my feeling looking at all that is it's going to be better with the chemo and the surgery than the chemo and the radiation. You certainly, get rid of, not quite as many, but it's not a big difference. But I would say it is a difference. It's not quite as good. Number 3, you could do radiation alone. And once in a while, radiation alone might get rid of everything, but not nearly the chances with the other 2 options. The radiation, you probably have, we'll talk about the radiation and then come back to talking about these. You guys probably have some idea of the radiation.
Oh, I just know what my husband went through.
How difficult is it with the other organs?
Yeah, so we'll talk about that. So, the radiations.
I mean, he just sailed through, Dr. Henning. He didn't seem to have any.
I'm different.
Yeah, it did a little bit different treatments, and we'll talk about that.
Right.
So a lot of the general things you'll know, though, Monday through Friday, 5 days per week. Usually we have the folks in and out of here in about 30 minutes, 15 minutes or so in the room, 1 to 2 minutes where the machine's on. And each treatment's like getting an x-ray. Really don't expect to feel
How many
anything.
treatments?
Something like this would be in the range of about 30 to 35. We start with the planning where we make a mold. And that's a bean bag we put under the hips and thighs. So we make the bean bag. We get a CT scan in that position with no contrast. We do a bunch of work on the computer
To pinpoint?
to localize things. And then there's the tattoos. Couple dots, you may have seen them like that. And what happens each day when the folks come in is the machine looks something like this. So we get them on the table like that. Get the mold or beanbag out, get them up in position. There's laser lights in the room. They line the tattoos up to the laser lights so the folks are all straight and level. And then the patients are lying like that. The radiation comes out of this part of the machine. And if you look up there, it's these thin, it's a lead-type metal. And what that does is that shapes or focuses. And, sometimes these will be fairly simple. It might just beams, 4 beams, front, back, sides. Sometimes they're more sophisticated, like we do with the prostates, where it might be 7 or 9 different angles. So the folks just lie there, and the machine rotates around, It comes on from each of those angles for a little bit of time. You can tell them all what it's like.
Right.
And, just moves around, get up, you're done. And like I said, something like this, probably in the range of about 30 to 35 treatments. So 6 to 7 weeks. So that's what would be happening with the radiation. And that would be the same, essentially, radiation alone or radiation and chemo. The side
Now,
effect.
can I ask you something
Yeah.
about that chemo?
Mm-hmm.
Is
Well, let
that-
him finish the radiation. He's still doing radiation.
Okay.
Keep that thought.
I'll lose it.
That's why I said keep
I'm
it.
82.
No, so we'll kind of wrap back to talking about these. The side effects. During treatment, people can be tired coming in.
This is with radiation.
Yeah, yeah. If you do chemo with it, they would be more tired. Bladder irritation. Now, when we treat the prostate, we're hitting just the bottom of the bladder. With this, for most of the way, we're hitting the whole bladder. So most of the people treating a bladder will have more urinary things than somebody would with a prostate.
Like more bleeding?
No, the bleeding will often stop very quickly. When you radiate, a tumor that's bleeding, very often in a week or 2 that stops bleeding.
Oh, because I have had some bleeding since cystoscopy.
Mm-hmm.
And that maybe I shouldn't become alarmed, but I find if I drink lots of water,
Uh-huh.
I don't seem to have the bleeding or the
Okay.
blood in the toilet. But if I don't drink 5 or 6 bottles of water, then I find I'm having bleeding, and
Okay.
is that nothing to worry about when I see it, or is that a
Probably
trip?
not.
Okay,
I mean,
but that doesn't mean a
yeah.
trip to the emergency room then
No,
when I
no.
see that.
I mean, if it's a whole lot of blood, then you'd have to worry. You know, that it's
What
not
is the
stopping.
irritation that she would
Yeah.
feel?
So the bladder irritation would be more frequent urination, so you're going to have to go more often. You know, a lot of people will have some burning, you know, maybe slow flow, waking more at night. But, you know, having to go, you have to get there, you can't wait as long, going more often and burning. Most people would have, you know, a fair amount of that with the radiation.
Okay.
Any skin irritation?
Probably not, typically not.
Okay.
Particularly if we're doing, you know, something a little more sophisticated, 7 or 9 beams, that would be a skin reaction like a prostate. You know, usually it
Do
would
you
be
have to
pretty
drink?
little.
What's your estimate on the amount of water I should drink? 4 bottles a day? Is that plenty?
That'd probably be more than enough.
Oh,
You know,
good.
just whatever you're
Because
used to
the more I
drinking.
drink, the more times I have to get up at night.
Yeah.
I mean,
Well, of
first
course, that
night I
makes
got up
sense.
9 times, and
Yeah.
you know, Jack said, "Geez, did you get any sleep last night?" And I said, "Well, I was up 9 times." And I really go to the bathroom. I mean, it's not like I'm thinking I might have to go.
Well, 8 or 9 bottles of water, you will.
So the other thing is, you know, the bladder sits right in front of the rectal area, and particularly if we're treating some of the lymph nodes, you know, you can have some irritation. More frequent bowel movements, urgency. You know, people say when I have to go, I have to get there. Loose bowels, diarrhea. So all of those would be things that you'd see. If you're doing chemo with it, more likely to have those bowel issues. So, you know, a lot of the chemo drugs, if you're doing the radiation, you have more of those bowel things.
Now, with the chemo, is it the real hard chemo
Yeah,
that
well-
you lose your hair and you?
You know, when you do it with the radiation, generally not. Usually it's a fairly low dose. And what that does is, the way I think about it, it kind of weakens the cells up, you know, to make the radiation more effective. It's not big doses that are going to do a whole lot on their own, but it does help the radiation work better.
So
That's option 2.
Yeah.
what's your feeling on it?
Well, here, let's talk about long-term things with the radiation.
He's still
and
talking
then
about
we'll come back.
radiation.
Okay.
The bladder, you know, what you'll see long term is you can have some scarring in the bladder. So the bladder, you know, kind of doesn't contract as much as it did. It doesn't stretch as much. And the good thing is, you know, some of the people we see have these long histories of, you know, low-grade bladder cancers where they've been scraped, you know, and had things, you know, superficial things scraped out, you know, half dozen times, and there's a lot of scar in there. It doesn't work too well to begin with. You don't have any of those, but you still could certainly see, you know, the bladder doesn't stretch as much, so it doesn't hold as much, so you have to go more often. You know, you can't wait as long. You know, some of those issues then can lead to some leaking, so people say, I can't hold it as long, I can't wait as long. So, you know, certainly some of that long term, it would not be unusual.
I have a little of that right now.
Tell me, the bladder is located, you said, near the rectum.
Yeah.
Can you show me with your hands, like, or a diagram, like
Yeah.
how?
So,
what,
you know, the bladder's right here,
yes.
and then, you know, the rectum comes down like this.
Okay, and then you've got the ureter tube that.
The urethra comes down here.
No, the ureter isn't
Oh,
it?
the ureters. Yeah,
Or
the
your, I
ureters
call it.
come
I'm
up.
sorry. And that connects to your
Kidneys.
left kidney, right
Yeah.
kidney.
Mhm.
The ureter.
Yeah.
Mhm.
Okay. And where does Dr. Gleese feel the outside growth?
Probably along that.
Okay.
ureter is where.
By the ureter.
Right. That's,
Okay.
That's what I thought.
Okay.
So the other thing, bowel changes. The bowel changes usually clear up, get better for people, but you know, there's certainly people where they don't go back to normal. You know, they'll say, I used to have 1 a day, now I have 2 a day. They're softer. People say more frequent.
But I have
Um,
that, what do you call that with your bowels anyway?
Oh, diverticulitis.
Diverticulitis. I mean, it's not real sincere.
Yeah.
Doctor, the last colonoscopy I had,
Mm-hmm.
Dr. Perlman said it wasn't light, but it wasn't heavy.
Mm-hmm.
He said it's just in the medium range.
Mhm.
So
Would
I
that
have to be-
increase
then
that, or-
lactose intolerant, I have to be very careful what I eat
Mhm.
anyway, because, it'll cause diarrhea,
Yeah.
so, I'm used to
Would
those
you,
kind of
would you
changes.
recommend her diet changing anyway?
So during treatment, when people have these things, a lot of times we'll talk to them about tweaking the diet. If they're having a lot of bowel urgency and loose bowels and diarrhea, we'll talk to them about that. Long term, most of the people go back to eating the foods, but there are some that can't. Some people say, oh, if I have a big salad, that'll set me off. I know I'll have diarrhea, this or that. So they'll have to be a little careful. I saw a lady the other day that, if she watches what she eats, she doesn't touch certain things, she's fine. But she knows if she has those, it's going to set her off, and she might just, if she's going to have one of those, she takes an Imodium and manages that. So, you certainly hear some of the people long term like that. Sometimes they'll have these clusters of bowel movements in the morning. I saw a guy yesterday who had that. He knows he gets up in the morning, he's going to have 3 or 4, and he just, after
Something you
about
have
an
to
hour
adjust
and
your
a half.
living habits.
Yeah, he says if I have an early appointment, I get up, I take an Imodium, and that takes care of it. He's retired. He goes, I just don't schedule anything before 10:30. Most of the days unless I really have to. And he knows he's going to have to run a couple times in the morning, but then it's going to be all right. So,
Right.
some of that stuff you certainly hear from people. Not that unusual. Really severe things, pretty uncommon.
Okay.
Other things, treating down in that area, there's some of the small intestine, some scar tissue from that. What it's called is adhesions. That's a term.
Mm-hmm.
So you get adhesions, it's scar tissue, and that scar tissue as it forms can like twist and kink the bowel. So there's a small risk of, something like that would, give you like a blockage or something. Not often, but over time you do have a risk like that. And the bone down there in the pelvis, real small risk of, a fracture related to a little bit of weakening of the radiation. And that's about it. Maybe some, vaginal irritation, dryness that can be an issue long term as well for women, so sometimes that's an issue. But that's the long term issues with the radiation. So coming back, that's the radiation. Radiation alone's an option, not going to be nearly as good as chemo and surgery or chemo and radiation in terms of getting rid of this.
Well, you have to
So
look
talk
at my-
about the chemo now with her.
So
you talk about, I have to look at it through my age too. That surgery might get me,
Well,
It's gonna take-
he'll
So, what the goal with the chemo and the surgery would be to completely eradicate this. You get rid of the cancer and it never comes back again. And that's gonna have a
if I was
better
60,
chance.
there'd be no question.
Mhm.
But
What-
I'm 82.
okay, but his
You know,
opinion, you were going to
and-
ask his opinion.
But I'm 82, and I just want him to hear me. And I don't want to spend a year in bed recuperating or 6 months recuperating from the surgery. I'm sorry, I don't mean to take up
No,
all your time.
it's just my page has come through. Okay.
So I want the easiest, the quickest,
Mm-hmm.
and get on with my life. If it comes back, it comes back.
Yeah.
I'm 82 anyway.
Mm-hmm.
I've had a wonderful life. I've got a wonderful family. I've got a terrific husband. Good Lord has been good to me, and He's going to get me through this.
Mm-hmm.
So that's why I had pretty much settled on just the radiation,
Mm-hmm.
because I didn't want pile on chemotherapy too.
If and so if you said, okay, I don't want when they do the chemo before the radiation, that's a bigger chemo too. I'm good crossing that off the list. What I would come back and say is, talk to the chemo people about what they would be looking at doing chemo with the radiation.
And you think that's best?
That would be much
Yeah.
better than radiation alone in terms of taking care of this, getting rid of it.
Would she need a port?
You know, that's a good question. I know there's a couple different drugs they'll use, and so they would talk to you about whether they would recommend them.
You
or
wouldn't
not.
write the prescription for the chemo?
No, it's the medical oncologist, the chemo doctors. So they would, talk to you, look at your history, decide which of the combinations we typically use with the radiation they would recommend.
Would you have it at the same time?
Yeah, so
Chemo and-
I mean, some of it would be IV drugs. A lot of times it would be IV drugs that they do like once a week. So
For the chemo?
yeah,
Oh.
so one day a week you'd get the infusion over there and then have the radiation here.
Oh,
Sometimes pills, so sometimes it would just be some of the pill chemo that you would
Oh.
take every day during the
Okay.
radiation.
and then would it still be everyday radiation?
Mm-hmm. Yeah, the radiation would be the same.
Yeah, I would go with that. I mean, the IV chemo. That's pretty much what you had, wasn't it? The
Well, I
IV?
had it through a port, but,
Mhm.
they had to adjust my medication afterwards because of the nausea, but I was never sick from the chemo.
And it's the breast cancer is
It's-
different. They,
it's a little-
oftentimes it's a couple drugs where this would, often be just like one drug at a time is what they'd be looking at.
See, the first 4, mine was a combo, and the second 4 were
Okay,
Taxol. So,
all right, so that would take.
Would this
right.
chemo be a low dose, right?
Yeah. So you get like 4 cycles of AC.
I did.
Yeah. Nothing like that.
I told you
So
it's
what
different.
would-
Yeah.
What, how long would the period
Oh,
of
how-
time?
Usually that
typically.
would be, just during the course of the radiation.
Oh, so that would
Mhm.
probably.
So if you had
five
30
to
treatments,
six-
it'd be 5.
5
Yeah,
treatments.
5 or 6. Yeah.
Right.
And
Okay, that
and do you
doesn't
feel
sound
comfortable? If she didn't say anything about
Mhm.
the age and whatnot, what would you have recommended?
The first, the primary, what we usually do would be the chemo and the surgery, take out the bladder.
You would have recommended that.
Yeah, if
But
Dr.
not
Galais,
too.
Well-
you're in good shape. If he felt comfortable, if, the anesthesia signed off on it.
So in your experience, have you done that before,
Done what?
where the chemo and the surgery?
Oh, yeah. Well,
And-
I don't do chemo and I don't do surgery, but that's what
Okay,
most of the
patients
people
that
would have.
okay.
A tumor like this, that's what most patients would have.
And how and in your experience,
Mhm.
how successful was it with these patients?
That's
At my
going to
age.
have a pretty good. You have to talk to Dr. Galais about what he thinks, how you would do.
He said, I see you,
Mhm.
I hear you,
Yeah,
and I understand where you're
Uh-huh.
coming from.
And he also
And I
said,
do
I
too.
don't look at age.
yeah.
He doesn't look at age,
Yeah.
but I'm looking, what am I gonna gain from that
Getting
surgery?
completely rid of the cancer.
Getting rid of the
Mm-hmm.
cancer, but in lifetime, I probably
Your
would live
chances
that
of
long
never
anyway.
having that cancer come back are going to be better with that than any other option.
And I know you don't want to suffer from the cancer either.
But I don't wanna go through, I mean, you've got
She doesn't wanna go
6
through
or
a mammogram.
7 different surgeries that you're going through at the same time.
They're
And so
procedure.
you've got 6 or 7
Procedures.
or 5 or 6 different areas that you could have complications with, and I don't wanna give myself that opportunity. I would rather take a chance on the chemo coming back, on the tumor coming back with, I would consider that chemo and radiation, if it's the mild chemo.
Mhm.
I mean, I don't,
She wouldn't have to take
I don't wanna
Neupogen
be
or
sick.
Neulasta.
Be
Or-
pretty unlikely.
Okay, that's what made me, that was what you saw. The bone pain because of that.
and I wouldn't have to have that.
No.
So what I'm thinking is let's get you set up to see the folks next door to talk about the chemo, what they recommend, and then I'll see you back after that and we
Okay.
can
She can make a
finalize
decision.
things and we'll have you on to do the planning if that's the way we're
Okay,
gonna go. We'll
that's
do
the way I'll
planning
go.
at that time.
That's the way I'll go, Doctor.
All right.
I needed that little push. Well, I mean, he made me feel relieved with,
The chemo.
the-
You're
Explanation
thinking,
of-
everybody's different.
yeah.
And every case is different.
Well, I've seen what you've gone through,
It's different.
It's
and
way
you were
different.
50, and that was fine.
Right.
And I would go through everything, I would go through the surgery if I was 50.
But see,
But I'm 82, and I want the rest of my life, even if I do, even if I get 2 years,
Mhm.
I mean, my mom told me a long time ago that the women in our family don't live past 76.
Wasn't that great?
So my sister and I have a big party every month because we've lived another month past, and I'm pushing 82 very close. And so,
You're doing
Let me
fine.
go put those orders in. Diane will come over. We'll get you all set with some appointments.
great. Thank you
All right.
so much, Dr.
You're
Henning.
welcome.
I appreciate your
Thank
time.
you.
Thank you.
Thank you for letting me take for my
You're welcome.
brothers.
You're welcome.
Saves a lot of texting.
So, what are we gonna, oh, Diane.